My name is Kevin Quigley, and I'm the Scholarly Director of the McEachern Institute for Public Policy and Governance, and I'm pleased to kick off today's panel, launching C.A.R.P Nova Scotia's position paper, Working Together to Bring Home Care Home. As we begin this event, the McEachern Institute acknowledges that we're here today in Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq people. We all recognize the histories, contributions, legacies of the African Nova Scotian people also, who have been here for over 400 years. While we're in Nova Scotia today, the issues we will discuss are of national concern. I'd like to recognize that we have people in our audience today that are representing C.A.R.P chapters from across the country. We're pleased to welcome our C.A.R.P audience members from St. John's, Newfoundland, from Ottawa, Toronto, and Sudbury in Ontario, from Regina in the Prairies, and from Surrey, BC. Welcome to one and all. We'd like to thank everyone for attending today's discussion. We encourage you to stay until the very end, and there will be a call to action presented by Ron Swan, who's chair of C.A.R.P Nova Scotia. Finally, this is not just a one-day event. We'll continue to remain active in this policy area. Please note on July 6th at 4 p.m. Atlantic, the McEachern Institute will be hosting a special event in commemoration of the 100th anniversary of the late Alan J. McEachern's birth. The event includes a panel discussion on the future of long-term care in Canada and reflections on the legacy of Mr. McEachern. Please visit our website at dal.ca/MIPP to review the program and to register. I'm now pleased to introduce Mary Jane Hampton, our moderator for today's discussion. Mary Jane is one of the most recognized health policy specialists in Atlantic Canada. She was Nova Scotia's Commissioner of Health Reform, where she was one of our principal architects of Nova Scotia's Health Care Blueprint. Today, she's a health consultant and regular contributor to CBC Radio. Mary Jane, thanks so much for joining us today. Over to you.
Kevin, thank you so much. And it's an absolute pleasure and privilege to be with you. I will make my full disclosure in the world of pandemic planning and home offices. I do have my Director of Privacy and Security here, who will hopefully be quiet for the duration of this webinar. But thank goodness for mute buttons. I think it would be fair to say that COVID has exposed fault lines in several aspects of our health and social service sectors, but none more so than in continuing care. And if anything good can be said of the pandemic, it would be that it's been a disruptor. And that's often what's needed to stimulate innovation and accelerate change. And that's absolutely where we find ourselves, and how I think we need to take what we've learned over the last year and a half and apply it to a better future. Because getting back to normal was never good enough. Today is an incredibly important conversation about home care and how it fits in that new and better future. And we have an absolutely fabulous panel lined up to speak to some of the challenges that are required to improve home care, not only in Nova Scotia, but across the country. Because as Kevin has said, this is not a challenge or an experience that's limited to one province. It's an issue that we share as a nation. So to start things off, I'd like to introduce our first speaker, who is Bill Van Gorder. I'm sure that he is known to many of you. He's been a thought leader and a shapeshifter for longer than he probably cares to remember. Bill is the Chief Policy Officer and Chief Operating Officer for C.A.R.P. He was also the founding chair of C.A.R.P Nova Scotia's chapter in 2007 and is now their senior spokesperson. Today, Bill's going to be presenting C.A.R.P Nova Scotia's new position paper, which outlines 5 priority actions to transfer home care in Canada. So Bill, over to you and your thoughts for us today.
Well, thank you very much, Mary Jane. Certainly appreciate the introduction and appreciate the opportunity that the Nova Scotia C.A.R.P chapter has given me to take part in this. In my role as the Chief Operating Officer for C.A.R.P nationally, it's such a pleasure to be involved in a program that is a set a standard for chapters of C.A.R.P across the country in terms of the quality of the work they've done and the partners they've been able to bring in on the program. I'm going to go through a set of PowerPoints for you all to see and briefly outline the program. I do want to point out, of course, this is a part of a national campaign where home and community care is a major focus for C.A.R.P right across the country. As most of us know, I think, only 5 to 7% of older Nova Scotians live in long-term care institutional facilities. 90 to 95% of us still live in our own communities, in our own homes, in our family homes, or in apartment buildings and other facilities. And those are the people that often are forgotten when we think about looking after people in the long term. And home care is certainly a part of it. This policy paper has been developed by an expert panel, and Nova Scotia has done such a good job in bringing together home care recipients, academics, researchers, home care providers, and other health professionals. I'm going to go through the program very briefly. I do want to remind you that the entire policy paper is available online on the C.A.R.P website at C.A.R.P Nova Scotia, all spelled out, .ca. So we hope that you will also take a chance, an opportunity to look at that and make sure you're familiar with everything as I just highlighted. Next slide, please. So what C.A.R.P is calling for is a renewed provincial approach to home care. It has to be well funded and implemented cooperatively by the Department of Health and Nova Scotia Health and all of the other service delivery agencies and organizations who are involved. And to make home care what it should be for our vulnerable older citizens, the people to whom we owe so much, there are 5 priority actions that C.A.R.P believes should take place. And I'm going to talk about each one of them separately. Next slide, please. And the first of them is focused, person-centered, family-centered home care. The institution of healthcare in Nova Scotia for too long has focused on fitting the clients into the system. We need to change it to a system that serves the families and the patients, the seniors who are involved, and make sure they are able to keep their dignity, have their participation and their choice. So often recently we have heard older Nova Scotians say, I want decisions made with me, not for me. We also need updated home care standards and tools to enshrine the person and family centered values and make sure that families are included in the process, as they are so vitally involved in the support and the care of their loved ones. Next slide, please. The second area is on staffing. We must increase recruitment, retention, and the quality of home care human resources. Home care worker recruitment and training has to be expanded. We know that Nova Scotia does have one of the better worker recruitment and training programs in the country, but it's not good enough. We need more, we need better, and we need to support them better. We need a home care human resource strategy that will not only supply the workers, but keep them working happily and well-trained as they look after our loved ones. And that means our compensation package has to be more generous. We need educational support, sick leave, on-the-job supervision, guaranteed work hours, paid travel, wage parity, and everything that puts them on the same level as other healthcare workers. We cannot continue to treat our healthcare workers at this level as second-class citizens. Next slide, please. And there has to be improved communications. One of the great downfalls of our system is communication is not strong between the policymakers, the implementers, the providers, the clients, and the clients' families. They all must get timely, accurate, and useful information about their care options, and they need to have them ahead of time. They have to know. One of the big problems we have, is most of you know, in home care today, is often the need for it comes up instantly. Families have to make a decision in hours or a day is what's going to happen, and they don't know what they don't know. We have to make sure that that kind of communication is built up ahead of time. We need to have those interpersonal, intercultural communication skills at all levels. A cookie cutter approach and a communication on Facebook and digitally is not the way to improve home care communication. The quality of home care communications must be improved. Next slide. The fourth area is transparency and accountability. We need a plan. We need a plan that everybody understands, and we need a plan now. Promises of plans. We had one promised in 2015 that we're still waiting for. We know that it's being diligently worked on, but waiting that long is too long. If you're 85 years old and you're in home care, saying that you're going to have to wait 3 years to understand what's going to be happening in home care is not a sufficient answer for you. The fifth slide, please. Expanded untaxed home care financial support. There must be increased funding for home care. We need enhanced caregiver and support programs. We have to simplify the reimbursement process. C.A.R.P believes we should eliminate the federal tax on direct caregiver benefits, and we should introduce provincial tax credit for family-funded expenses in home care. Next slide. How can you help? Ron's going to be talking about this a little bit at the end of the program, but remember, we can sit here at C.A.R.P Nova Scotia or C.A.R.P National and suggest all the things that we like. Change will only happen when you talk to the people you vote for and say you want change in home care in Nova Scotia. Talk to your local elected representatives and candidates as another election looms. Talk to the media about your concerns. Join C.A.R.P and share the work with us, support what we're doing. We have 10,000 members in Nova Scotia. If we had 20,000, we would be even more powerful with government. Consult our website at www.carpnovascotia.ca. Over to you, Mary Jane.
Thank you very much. There is a lot to unpack from that presentation, and I would expect that each of those points will resonate differently with people, not only across the province, but across the country, Bill. So thank you very much for that. Going to move to the panel portion of today's meeting, and we have 3 panelists with us that I'd like to introduce you to. The first is Sandra Ball. Sandra is a nurse by profession. She's taught at the Victoria General Hospital School of Nursing. She's worked in long-term care and was an administrator in home care for 19 years, including as director of home care at Northwood. She's now retired and continues to be an advocate for better home care for everyone. So Sandra, welcome. We also have Donalda Mcisac. Donalda is a community volunteer and health advocate. She's a member of several committees, including the C.A.R.P Health Committee, and is the co-founder of the Diversity and Healthcare Bursary that's funded by the Acuity Foundation. So welcome to Donalda. And we have Grace Warner. Grace is a professor in the School of Occupational Therapy, and she's been conducting research on community-based health services for older persons for over 16 years. Much of her current research is specifically related to home care, which gave her a direct track to this panel. So thank you for being with us. And what I would like to do for the 3 of you is maybe start with Donalda and ask if you could share an experience that you've had as a family caregiver that maybe exposes a problem that needs to be addressed in home care today. And if you just want to run with that, I think that would really help us to set the stage to take us from the policy level to the personal level.
Thank you very much, Mary Jane. Well, I started this journey over 20 some years ago, and what makes this somewhat of a unique journey is that my son has a very unique condition that basically the doctor says is off the charts. So that would be the introduction to coming into home care. What was really amazing was not knowing anything about home care. So once we started into it, it was very overwhelming. Right up till today, I continue to have struggled with a lot of the same issues that I struggled with before. Sometimes you don't have someone show up for a shift, or your hours are changed. There's a lot of different barriers that are there. And oftentimes one of the hardest times is Friday afternoon, because everything's shut down on Friday afternoon. So if you don't have service on Friday afternoon, you don't have it. Or one of the things I really find difficult is coming into holidays, because again, on holidays, you're somewhat cut off. You are the person who, when someone comes through the door, you're responsible for teaching what has to be done in your home. And oftentimes somebody will arrive at my home and they haven't been told anything or how to care for my loved one. What I try and have always tried to do in my home is make sure that it is person-centered care, and that my son's needs become the most important needs that you have to deal with. It's really hard when you're trying to care for your loved one, and it just becomes overwhelming at times because the resources aren't really there for you. And as caregivers, you're doing 24/7 without a break most of the time. And so a lot of the times we work on the adrenaline, and it's very hard to reach out and ask for help from your providers, because oftentimes there's no place to turn, or you don't know where to turn. And so for myself, after doing this all these years and still finding it very difficult in the system, I'm very sympathetic to somebody who's just coming into it.
Yeah, I think that is that's a profound level setting, and it speaks to the fact that while home care is something that we think of for seniors predominantly, it does address the whole age cycle, and you can't unpack the impact on family caregiver in providing care and support in a home care environment. So I think that nails it. Donald, just looking at the presentation that Bill made, would there be anything particularly in that call to action that you would say, yeah, we absolutely need to do this piece, or is it all of it? And it's fair if it's all of it.
Well, I think we pride ourselves on the 3 C's: the communication, the consistency, and the competency, because those are the things in all of what Bill shared is what makes it work. The communication is a very big part of it. And being able to communicate what this individual needs is very different from what the next individual needs. And we have to take home care out of the blanket phase and realize that each person requires a different sort of care. We have different care in community. We have some people who need assistance from their day-to-day routines, but we also have people who require another level of care, which becomes more along the nursing levels of it. And so our paper that Bill was addressing speaks to all of these issues. And in all of these issues, the communication and transparency is very big.
Well, that's a beautiful handoff to what I was hoping Sandra might be able to address, because you've given us the family perspective, which really speaks to that importance of the human resource component and the paid work in home care. And Sandra, I know a lot of your experience has been in the area of recruitment and retention, and I just wonder how what Donalda has said resonates with you, and what would be your takeaways in where the priority areas for home care improvement really lie.
Thank you, Mary Jane. I would certainly, I hear everything that Danelda is saying, and it was certainly my experience in the years that I was involved with the home care provision world, and very much needing to as well endorse all of the points that Bill made in the action items on the position paper. I came into the world of home care in 1996, and that was as the services were devolving from the Department of Community Services to the Department of Health. It was the Department of Health then, but now Department of Health and Wellness. And it really was a time of opportunity and growth, and because the services under the Department of Community Services were certainly very much useful. And I would say that the folk who were receiving services in those years would endorse everything that was happening with them. But we know that it was being delivered through many municipal and nonprofit, not-for-profit organizations. And it was certainly speaking to the needs of the recipients at the time, I would say. However, once the Department of Health and Wellness came on board, then many more, I guess, needs for the system were identified. And in particular, I would say that the need for consistent and reliable education was one that I identified, and so did many of my colleagues at the time. We went about from there establishing partnerships with curriculum providers. Some of those were private providers. The Nova Scotia Community College was on board, and we set about developing, it was called at the time, the Home Support Worker Program. And we wanted to ensure that all employees of all of our agencies throughout the province would have a quality background education. And that was, I would say, no small feat. However, I do want to say that we had excellent resources within the sector at the time, and we had the cooperation of those bodies that I mentioned, the Nova Scotia Community College, private career colleges, and of course funding through the Department of Health at the time to put on courses and really provide certificates, a certification program for employees. So I think that's very important, and would say that it's also remains important. As home care and continuing care services evolved, the continuing care assistant was born. And at the time that it was announced that there would be a program for these folk for the sector, and that would be for long-term care and for home care as well. The Home Support Worker Program, that curriculum was started. It was the baseline for how the Continuing Care Assistant Program evolved, which I think speaks volumes to the work that the home support industry put into the consistent education for their employees. And also the area of communication, as Danelda speaks, is, it can't be emphasized enough how important it is to repeat and repeat again that we need to ensure that people understand their role, that the home care providers are going into an environment that is unique to each individual with which they interact. That is often different than, an institutional setting. However, it really needs to be emphasized. So the work that goes on with home support is around the person, is around the family. And as Bill has emphasized as well in his introduction, the policy, you can't fit people into policy. We have to work around the needs of people and ensure that they have what it is that will enable them to thrive actually in the home care setting. The other area that I think, and this is also noted in the paper around recruitment and retention, so much work began in those early years, 1996 onward, to really acknowledge and recognize home support workers as a very valuable contributor to that continuum of care. At the time I joined the sector, home support workers were receiving a minimum wage, if that, in some cases. And they really had no idea from week to week as to what their actual salary, wage, income might be, because home care in those days and somewhat now is piecework. So they might be paid, or they would be paid, for the hours of care that they might spend in someone's home. And they may not be paid for the time it would take them to get from home to home. So for instance, if they had 2 or 3 people to see for, say, 2 hours average each, that would be 6 hours, but they may have to be out in the territory going from place to place for another 2 or 3 hours, depending upon where those clients resided. So there would be, 9 hours, but they would be receiving income for only the 6 hours. So lots of work had to be done. And I'm saying this with, sort of tongue in cheek, but I really believe that the agency that I joined in 1996 was Dartmouth Community Homemakers Association. I believe we were the first home support agency in Nova Scotia, or at least one of 2, who then became a unionized work environment. And I welcomed that because it was certainly time for action. It was time for the home support world to be recognized for at least a living wage, benefits, because there were very few hours. If you were sick, you didn't get paid. This is a lot of the conversation that we're having now around folk working in other sectors during the time of COVID. But this was the world of home support back then. So a lot of work, a lot of commitment, a lot of compassion and education went into bringing home support workers into the world of really good work world, an occupation that was worthy of entering. I think more can be done, and I'm looking forward to perhaps having an opportunity to speak more on that at some other time.
Thank you. That is a very crisp overview of not only where we've been, but how we need to kind of map that journey into where we need to go. Because I think that you're right. Many of those challenges were tackled in the early 90s, but I think there are a whole host of legacy challenges that we've inherited from that time that we need to sort out to put home care and the continuing care sector generally on a more solid footing. Yeah. So yeah, absolutely. I guess to that point, I'd ask Grace Warner if the research that you've been doing in the sector lines up with the observations that Donalda and Sandra have made from the family caregiver perspective and from the kind of human resource side of the house. Does this stack up with what you're seeing, and what from a national perspective would you share with us as being in sync with C.A.R.P's position paper?
Yes, well, most definitely. Donalda, just the importance of caregivers is essential. They are the linchpin to home care, and so having said that, there's a substantial research that has shown how important it is to support family-friend caregivers, and to, and I've done some research about the caregiver benefit, of how important that is and essential to that, although how limited it is in what it provides. So there's, yes, there's, and also with the current research that we're doing in terms of looking at home care services, it's interesting to look at that balance. I mean, going to Sandra's point in regards to the balance between, there are some places that are, provinces that are using kind of saying, well, we'll hire home support workers on a phone. I'll use that general term. There's a lot of different terms, so I won't get messed up in all the different terms like continuing care assistant, etc. But let's say home support workers, that they're hiring people full-time and saying, okay, we have a home support worker, we're going to hire them full-time, and there's substantial benefits to that, to the individual. So, but the research is showing that comes with some drawbacks to individuals in terms of, okay, if you provide full-time hours, which I totally support, to the home support worker, then maybe that means the family doesn't get the same home support worker all the time, because they're trying to support this one who they're saying, hey, we're going to give this person those hours, and so therefore the caregiver isn't getting the consistency, which is once again over and over again, these things are seen in the research, the necessity of consistency. Each client, each home care client is unique, has unique needs. Families have unique needs. So, back a while ago, I tried to do things about looking at family-centered care in terms of implementing family-centered care, but there are a lot of issues in regards to the mandate of the province. It's not, they're the client, they're not the family. The family is not the client. It is, the client is the client. And so no matter for the sympathy of the people who are providing care, that that there is a need to consider the family's needs, that's not how it's written in terms of what they're delivering services. So if the home support worker goes into a home and is, tasked, when these days they're tasked with, a certain amount of time to create a meal, they don't have the time to maybe create a meal for the caregiver, which might be very helpful so that they have a break. So there are a lot of legislative things which, but I mean, as the evidence goes, there is strong evidence for the lack of consistency, the need to be able to, to support, family friend caregivers and whatever they need, and to address the individual needs. I think that's the big thing that keeps coming up in the research too, is really addressing to the client with the, well, I'll say client, but also I would family too, their needs. What are their needs? And there's a menu of things that can be done, that we can look at, that the research shows. Like, I'm involved in a study that looking at monitoring, remote monitoring devices. They're not for everyone, but if someone has dementia and you have monitoring of what's going on in the home when the family member, and that information is sent to the family member kind of knows when it's time to what's going on with the client. So there's, once again, I would, the research, substantiates my view that there's a menu of services, and we need to be able to have the research on the needs of home care clients. So they should be, and we should understand those needs. We should have also monitoring of things, and we do have tools within home care. There's a tool called the RIHC or the MDHC, which, so there's a standardized tool on every home care client that is done. But once again, it's supposed to be done every year. But resources, I think it, for me, a lot of time comes down to resources. Yes, we have a lot of good people in the system who are trying to do the best possible. And I'll end with the last kind of comment in terms of our more recent work is looking at that. Yes, we do want standards. Yes, we do want quality of care, but flexibility becomes essential too, because once again, if we're dealing with individual needs, there's a need to be a little bit flexible. And there you have the tension between, we have standards, and then we have what the individual needs. And so the person, the individual, the home support worker, the care coordinator, the home care agency is put into a situation where they have to balance these different things. And so what we're finding in our most recent research is flexibility and relationships. I guess I'll say one more thing is that one of the comments from someone post-COVID who was coming out of home care was saying, what was, what do they like most about their about home care? And it was, well, I like the smile on the face of the home support worker. There's huge relationships with certain individuals. It's essential for social isolation, for older adults. that are there. So there's a lot to be said for it. So I really thank C.A.R.P for bringing this forward, because it's an essential issue that we do need to kind of have discussions about and promote, keep pushing for better situations. But the evidence does support that we do, we need it to be better. Over to Mary Jane.
So, Grace, just picking up on that, and just I'm going to come back to Bill in just a second, but to ask you just one more question before I move on to Bill. Broadly speaking, government programs are set up to say, this is what you can get. But what you're saying is that we actually need a paradigm shift so that a home care program says, what do you need?
Mm-hmm.
And that's a tectonic change. So, it's easy to say that we need flexibility. I think that we'll be talking a bit about the need for some national standards as well. But what is that sweet spot? How do we craft in an environment where the whole vision of a program is to ask the question, what do you need?
Mm-hmm.
How can we help? Because that's what home care needs to be. Is there any jurisdiction that you have seen that you would say, if we needed to look at a place that's really figured home care out, take a look at that? Is there anywhere who's figured that out, or is this going to need to be a made in Canada solution?
Well, I'm sure there are lots of, I don't know everything that's going on in the world. I know when I did visit Sweden, I was quite impressed with a lot of the home care that's going on and community-based services overall. So there's another call for integration of services. So across different sectors, because home care is home care. Social, like for an example, in some of my research, housing becomes an important issue. So that's another thing that's in the research about integration of services. And I think there are some other more socially oriented countries that would, have been trying. Now, whether I don't have all the research on how well they've accomplished these things, but going into the home and integrating care, and I think it goes to the communication aspect, communication across sectors. I'm sorry, that if I go into our communication across sectors, it has a lot to be desired. The home care system is one thing, acute care is another thing, the primary health care is another thing. We have a special patient, program through the EHS service. And that's another research I was doing with someone. And that special patient program is a wonderful program where people can sign up, at people end of life, that they can have the ambulance come and no sirens, and they can, be on a certain list. But the communication, if the paramedic goes into the home, often, unless they have the green fold, they have a folder there they can write on, there's no communication between them and the home care. And so communication across sectors is kind of, I guess, one of the things that I've also been very frustrated or see again and again, let's say, in the research that comes up. So I think that, yes, we need flexibility. Yes, we need client-centered. We need to think about, we need to address people's needs, and we need to think about how best to assess their needs, because it is the responsibility of the government to then make sure that they're, monitor, what's being done. And, that comes at a cost if someone is going into a house with a task oriented and giving, so much money per task. It doesn't make, it's a totally different. So yeah, Mary Jane, the paradigm shift, I think, is what you're saying. And I think I saw Sandra kind of biting a little bit, kind of like putting her hand up a bit. So maybe I'll just stop right there.
Sure, Sandra, do you want to wade in?
Well, I do. Please, thank you. When you ask about would there be any other jurisdictions from which we in Nova Scotia might learn, I worked with a colleague for a number of years who worked in home care in Australia, and she always described and weighed in on many of the successes, and to Grace's point around it being integrated with the primary care, with long-term care, and so on. So that's a huge piece. There needs to be much smoother integration for the work of home care. And I wrote a little note to myself as Grace, as Grace was speaking, and as you asked, things certainly do go full circle, because when I came to understand the program of the Department of Community Services, the home care program that existed when it devolved to the Department of Health and Wellness, it certainly was far different in that folk who felt that it came, the referral came from people in the community themselves, and it would come to an agency that was in their community providing the services, and they were asked, what is it that you need that will keep you in your home? And it was really quite remarkable how the folk who then delivered those services did exactly really what the people were requiring and asking for. So when it devolved to health, a lot of that went by the wayside. And I'm not disparaging, what it was all about, but there's a lot that we could learn just from going back in our own province to that coordinated home care program of the Department of Community Services.
Bill, can I come back to you for a moment? I'm just wondering, having listened to Donalda and Grace and Sandra, what is it that you think policymakers can do to help shape and guide this change? I think you've been, very clear in saying that getting mobilization to make this a public policy priority is important for all of us to do. But practically, if we know that there are issues around compensation, we know there are issues around a lack of integration and a very siloed approach to how we plan and fund and deliver services. Is there any practical advice that you give to policymakers to start to unpack this and do good by home care?
I'm sure it's certainly hearing from the people who are actually involved in the service strengthens the points that C.A.R.P has been making. And what we want the policymakers to understand is that the entire healthcare system, as directed toward older adults, needs to be redirected. We know the province will never be able to provide enough institutional home care beds to meet the needs. We know that although huge improvement is necessary in that area, has been, as we've seen from the terrible outcomes of COVID, that in the long run, for the majority of older Nova Scotians, home care and care in their own community is going to be necessary. And it's very hard, we understand, for governments to change direction in the way that they have, like changing the direction of the Queen Mary. It's a big ship moving in one way, but that must be done, and we can't expect bureaucrats who are working under current policies and systems to be able totally to do that. We need policymakers to say, we want this change. We understand that home care, for all the reasons that have been outlined, home care to people in their own communities is important and must be done. So we have to break down the silos. We have to be able to move the money around appropriately in the entire Department of Health and elsewhere, so that we can get the care that we need for our loved ones. Until the policymakers decide and demand that this be done, we're going to be waiting years again for any kind of change.
And Bill, I think what you're saying is that the whole continuing care sector needs an overhaul and investment, because in fairness, I think this is the continuing care sector, home care, long-term care, and everything in between has really been the poor cousin of the healthcare system for a long time.
Well, it certainly has been, and for too long, we believe the healthcare system has been directed from a medical institutional, some would say a a hospital-centric point of view, that everything works down from that. And the person-centered home care that we're talking about, the person-centered care right across the whole continuum. And you make a good point that's probably worth emphasizing, Mary Jane, and that is when we talk about long-term care, we're talking about the continuum. We're talking about the kind of care that you need throughout your life to support your health, right through the kind of specialized care you might need in your own home, and then at the very end of your life, the kind of care you might need in hospital or another institution. It's a continuum. The whole thing has to be looked at. You can't treat just one piece and expect it to work out for all the others.
Beautifully said. I am going to suggest that we move on to the next part of our agenda, which is to open questions up to our audience, because I know we have a lot of people online and there may well be some things that they would like to put to the panelists. What I would ask is that if you could type your question in the Q&A box in Zoom, and if you could just state your name with the question, and if possible, just to make my job a tiny bit easier, if you could let me know if there is a panelist particularly that you'd like to direct your question to. And if you're from the media, if you could just let us know what media outlet you're with, that would be helpful as well. We're going to try to get to everyone's questions. We will be pretty disciplined about ending at the time that we promised, which is 12:15, but we'll be doing our best to get through as many questions as we possibly can. So while I let people in our online audience organize their thoughts, we did have a couple of questions that came in advance, and one of them was from one of my most favorite people in the world, Ian Johnson, who has, we go back many, many, many years, more hair colors than Ian would probably, being the gentleman that he is, acknowledge having seen me morph through. But Ian has been a long-standing advocate for improvements to community-based health and long-term care in particular. And a question that he has put that I'll maybe ask Grace if you would respond to, but Bill, you may have something that you want to say in response to this as well, is what is it going to take to get national standards in place for home care? And he's wondering if home care will finally become recognized as part of our national Medicare program, so that individuals or family members don't have to pay so much toward the cost of their care. So Ian gets that $64,000 question. And I think, Grace, if you want to tackle this from the perspective, as you said, of finding that sweet spot between standards, but still being responsive and individually and family based, that would be helpful.
Yeah, well, it is, the research is, standards, it's just the word standards. And standards also, are what we expect from, workers or from policies, from agencies, whatever, that are set to standards of care. And so I guess it's like how we set those standards. So that would be my, basis, because I am a measurement person. And so there is an often quoted phrase of like, we manage what we measure. So how are we measuring things within home care? So I would like to, maybe my thought is there is data out there, as poor as it is, because we don't have enough. That would be another thing. We don't have enough community level data to really understand what's going on. But there is data there that, for example, like I mentioned before, the standardized assessment that they have, which is the RIHC, where standards could be, set for those. But I also, then they have triggers or indicators within there to where care needs to change. Often those things aren't filled out completely. Often because, and what I have heard from is that because it's also kind of a within that kind of, and I hate to get kind of quality culture. It's a culture of like, I'm being assessed not to be punitive, but I'm being assessed to be able to see how I can do better. And so it's also a cultural change. So standards, to me, yeah, you can say people should do these things and whether people follow them, but then you also have to kind of create a culture where, yes, we are going to be following these. We're going to be, you know, filling out those forms to make sure that, you know, I'm tasked to do a better job each day to do that. And so there, you know, when it comes to, so there isn't, I mean, like I said, the RIHC is across Canada. So we do have the data across Canada. When you look at the standards, they're also kind of more policy oriented than they are for client oriented. And I would love to see it part of the Healthcare Act. So that would be one of my things. But once again, is that the will of the I figure that's more the will of the politicians. I mean, the evidence of the need for home care and the evidence that we, you know, you can prevent people. I mean, home care can be cost effective. I mean, might be on the backs of the family friend caregivers, which are giving a lot. And so we have to look at that. But I mean, it is cost effective to do that. And so if we allow, and then and is that a standard of care that people should be able to have and keep them out of an institution? So, which is more costly care. So yeah, I think that there is the will to dedicate the resources to those areas. And how will they? Yeah. So I guess I will leave it at that. I mean, I haven't answered it as well as I would have liked. I've thought a lot about the question, but it's a very, yeah, I think that their standards, again, are they're difficult to enforce. So not that I'm against them, but I'm just saying, you know, how do we make sure that we have client-centered care? How is that assessed to make sure that our care is client-centered? It has to come from the client. It has to come from their assessment. And then how do we assess that as satisfaction, as did they get what they were supposed to get? And so anyway, I would ramble on since I'm a measurement type of person, but that there comes the nuances of where you're doing it. But I think that there is enough evidence that's cost effective to do it. And there's enough evidence if we keep people at, you know, at home. Most people want to be at home for as long as they can. And, you know, even Donalda's point, you know, I'm sure that, you know, you do not want to put a child in an institution, you know, to ever, you know, to be able to do something like that. So anyway, so I will turn it over to Bill because I'm sure he has a very expansive and more policy oriented answer to that.
Well, no, well, thank you though, Grace. What your answer clearly indicates that there's a way of doing it. And Ian, hi Ian too, and Olga, his question is right on because as Grace said, there's a way of doing it. Will it be done? The federal government has been dancing around the issue of national standards for years. They've recently put the challenge before the Canadian Standards Association to come up with standards. And as Grace said, we already have them, and we probably don't need another study on how to do them. It really comes down to where does the provincial desire to keep control of healthcare in general and home care in particular, keep the decisions all to themselves and not let the feds get involved. What C.A.R.P nationally has told the Federal Department of Health and the federal ministers is that if they will introduce policies that create standards across the country, then C.A.R.P members across the country and all the provinces, we will advocate with our provinces to get on board, because the level of home care or any kind of health care you get should not be determined by your postal code. There should be equal high standards right across the country.
Well, that might be a quotable quote from today, Bill. Thank you. That's absolutely right on the money. And I think, you know, maybe as we have this national conversation, it's important to be talking about the future of the long-term care sector in the context of the practical limitations of the current Canada Health Act and the fact that it doesn't cover this stuff. So if we're really going to be brave about talking about a future state and not just try to nibble at the edges, I think possibly challenging the fundamental piece of legislation that underpins anything that is a vague semblance of a Canadian healthcare system, which in my opinion actually is a figment of our imagination anyway. You know, maybe this is the place to start. And I think that there is an appetite for that now. Donald,
Can I say something, Mary Jane?
Yeah.
I just wanted to sort of interject here. Grace hit it right across the board about a lot of what's going on. I think what makes my situation somewhat different, that even though we're talking about my son being at the age of a 24-year-old, he's actually, in medical terms, a 90-year-old. So that's what makes this so unique and why I'm very much part of it. But the system really does not focus in on the individual needs around what each person requires. And as caregivers, it's one thing to sit and listen to a lot of different discussions and papers and things, but the reality is these are going on every day. People don't have the time to continue to wait for decisions to be made. We need to do this now because people's lives are really on the line here, and COVID really has taken home care to a totally different level. If you think there was isolation before in home care, the isolation through COVID just made it 10 times worse. And, so it's very important to understand just what goes on in the homes right across the board. And you have people struggling every single day. And in those homes, a lot of times the fear and frustration that's there because the needs aren't met and you feel like you're on your own all the time dealing with these different situations. During COVID, for example, one perfect example, my house, for example, I've used disposable gloves and masks for years, and all of a sudden you couldn't get them. And now these same items that I paid $9.99 for a box of gloves are now $25. And so there's so many different things that have impacted home care that right to this day, people are impacted every single day when they get up in the morning. And these things really are serious enough that they have to be addressed. And, and we don't have time to just keep on thinking about how to do them. Government has to move on doing them. Thank you.
Well, Donalda, to that point, Yvonne Druin, who happens to be one of my most favorite psychologists in the world, has sent us a question that I think maybe you and Grace might be able to tackle. He's wondering if smaller home care teams headed by nurses, like the model that is happening in the Netherlands, might be able to better assess the needs of the person and family members. And I would put that question to you. Does that feel like a model in your circumstance that would translate into making things better?
I think that's something that actually could be looked at. Yes, definitely.
Grace, any research to back Yvonne's?
Well, I guess I was thinking about, I don't want to be professionally specific to who heads the team, but I think a team that is, kind of, because right now we have, like I said, I'm not disparaging anybody's role, but we have a team of a care coordinator at the provincial level, then the home care agency down here, and then we have the home support worker down there, and then we have that whole thing. That's just home care without referring to occupational therapy, physiotherapy, social services. So I guess when the team, I like the idea about coordination. So I think the idea from a broader perspective, when we talked about either integrated or coordination, I think a small team like that would be fine, would work well. But I think it's the idea of, once again, a team that is connected to the home. So, that there's an ability for the team. So, and there's a coordination of those services. So if it's a team that you can say, okay, it's headed by a nurse, they could go in, they understand what the situation, and they have the ability to refer to other services that are then therefore important. I know that because I am in the School of Occupational Therapy, I've done a little research with the community-based OTs and PTs in Nova Scotia. And, they were just saying, we're consultants and we basically consult, we give a plan, and then we're out of there, basically. So this is a while ago, and maybe this has changed, but, it would be nice to have someone go in, on a maybe kind of a, I forget the name, rehab assistant, go in and do the exercises with the individual so that you don't have, it's a little bit less costly, but it would still be kind of monitored by someone who could monitor it. So I guess that's what I would like from the question is like, well, we've got teams, but the teams are in touch with what's going on. There's an ability to refer to the people who need to be involved to make that happen. And there's a community, and that was one of the things I thought in Sweden is that, this whole thing of where it's out of the referral, like you're over there, and then you've got like 5 people coming to your home on one day, when you just wish that it was all coordinated and you kind of, everybody was talking to each other. So yeah, so I think it's a great idea, but there's, I think that the idea of coordination and care plans that are coordinated and not just, I mean, nothing medically oriented is wonderful, but we do need the other professions involved in there.
May
Sandra,
I?
anything you'd like to add to that?
I would. That whole the concept of the team, when as a service provider, we had the referral from the continuing care world coordinator for the services, we really then felt that we were the leaders, in that we were the frontline folk who were in touch with that family and client every day. And we had RNs that had caseloads, and they were assessing and listening to the home support worker feedback and so on, and also advocating to the continuing care coordinators for changes or additions or whatever. And as Grace says, someone has to take the lead. And I felt at the time we were I was working in the industry, that we really had all the tools to be the folk who could coordinate all of that care. However, again, policies didn't allow that. And there was, since there were inconsistencies as well in service provider agencies, I guess there wasn't an appetite for the either Department of Health and Wellness or Nova Scotia Health or whatever to kind of give over some of that leadership to the service provider agencies. But ultimately, they're the folk that are touching these people every day. And they would, in my estimation, be the people who could really do a lot more work and be given a lot more responsibility within the system.
Yeah, really good points. Somebody has suggested that in their time working in the sector, having had experience in Newfoundland and then in Nova Scotia, that the standards in Newfoundland in the 80s seem to be much better than the standards in Nova Scotia, which I think provokes another national question, which is, notwithstanding that we have this fabulous federated model of provinces and territories, does every province need to be inventing home care and continuing care standards and policy frameworks alone? I mean, is there not a core that would be reasonable to expect? If it's good for PEI, it's good for British Columbia as well? And is there any space, Bill, maybe this is a question for you, is there any space for that kind of national discussion to be facilitated? Because I think, and I would just observe that I think we've also seen the pandemic demonstrate some fault lines in other parts of the system, and public health is another one, with different provinces doing different things, using different evidence and rules about how to respond to something that we're all equally impacted by. So can the continuing care sector kind of do a proof of concept that there is some consistent approach to this and some table that we could set to talk about that?
I think you're absolutely right. And we believe that there could be and should be. Now, in fairness, the provinces do meet with their leaders in the home care and the long-term institutional care sector, do get together, do talk, do share ideas. But then the decisions come back to the local provinces, because it becomes a political decision and a policy decision. And that's why we are pushing the policymakers to be as cooperative as we know many of the bureaucrat leaders would like to be and are trying to be. And by the way, just to speak to one other quick point for understanding, there's been a lot of talk about changing the Canada Health Act to make long-term care, the whole long-term care continuum, to deal with it. C.A.R.P believes that trying to change the Canada Health Act is a many years process. It's not going to do what we need quickly. We think there should be a separate Canada Long-Term Care act and just deal with it, not try to do the whole thing at one time. And that would move the process along a lot more quickly than the politicians are talking about doing it now.
Fair enough. Donalda, I'm going to maybe cue you for this question because Anne has made an observation that she thinks that the VON is not being recognized as the fulsome player that they need to be in the big solution, and again spoke to some frustration in the lack of integration between what happens with VON and what happens with home care and what provider is able to provide what service, which in a home environment must be really frustrating when you have hands not clapping. What would be your response to that observation?
That's a very good observation. I mean, very good question. The thing is that it's very difficult to, it's very difficult because a lot of times I hear a lot about the care plans. The care plans are put out, but they're not necessarily followed. And I don't personally deal with VON, so I can't talk about the VON, but the nursing that I do deal with, it's all over the board. The communication just really isn't there. And it makes it very challenging when it's in the home because you become responsible for every single thing that your loved one requires. You become the person who's responsible for it if the nursing isn't communicating amongst themselves or even with the supervisors who have put the plan in place. I hope that answers your question.
Yeah, you have, and I think, you know, again, it speaks to those really practical issues that it's intriguing as well because sometimes it's also who the people are and the ability of just individuals to communicate with each other, because some of the stuff you can't program. I mean, the people are good at sharing and communicating or they're not. And if they're not, that's a huge gap that no policy can fix. So,
and there's another issue that, you know, even though it's a very delicate issue and people don't want to necessarily always look at it, it does affect what goes on in home. And that is a language barrier sometimes. And especially when you're dealing with, you know, adults who have cognitive issues. And they're frightened and they can't understand, or they have hearing issues. And, you know, you can't really understand the person providing the care. The person providing the care really can't understand you. So again, it comes right back to communication. And that oftentimes can affect the way things are done in the home and how the person receiving the care is cared for.
I have a question for Sandra. And it is from Jocelyn. And the question is, oh, actually, no, sorry, I keep bouncing around here. Yes, question from Jocelyn. Home care accommodations and accessibility is an important component for us to address as we move to the home first approach. Are we also advocating for funding and red tape reduction for this? And this is actually from Alice.
Well, absolutely. If indeed, as Bill and Donalda and Grace speak to, if indeed we are going to be required to fit people into policy, it won't work. So yes, red tape needs to be changed, you know, needs to be cut, and we need to have a lot more flexibility. Again, Grace spoke to that, and it is certainly about making things happen, because I often would say we have what we need. We really do, though, need to look at using it in the best client-centric approached way.
And I have one probably last question, just in looking at time. And this question is for Grace. So Grace, working in long-term care for over a decade, this person is asking, they've seen a shift in clients being admitted and their level of frailty dramatically being increased. So they would assume that clients within community care are requiring a much higher level of care as well, staying in the community for much longer. How do we ensure that caregivers' education is being adjusted to reflect that change in acuity and that burden of care?
Oh, that's a really good question. That's a really good question. And I would just, yeah, support that. I think I saw the heads just nodding here, but yeah, and I know the research is, yes, this is true. You know, that home care clients are more ill and long-term, and they're being admitted to long-term care facilities at a later stage and are much, you know, well, maybe that's a good thing in that they may be staying home longer, but you know, that would be the positive side. This is it's difficult. It's difficult. I mean, how do we, you know, tackle this problem? Um, I don't know if I have a really good answer to that. I don't know if I really have a good answer to that. I think that education is important. You know, and who do you get the education from? And you know, there are some caregivers that, like, you know, it's hard to ask for help. You know, and I think that in some ways, you know, that I mean, I've seen from our research that, you know, family friend caregivers want to be respected for their knowledge. They want to know about the person that they're caring for's trajectory, their illness, what is needed, and they want to be a partner in that as much as they can be or desire to be in that piece. So the education is important, you know, and so hopefully that, you know, should be coming, you know, from should be available on many different fronts. I mean, I know that Caregivers Nova Scotia, you know, does do some as much as they can, but they do more peer support than they do education. So where does the education come from? I think that that would be great to I'm trying to think, where would it come from? Maybe it would be from the home care agency, Sandra, in terms
Yeah,
of
you see my hand up.
I
Most
could see you do
definitely.
that. So that I
Yes,
think that
yes.
maybe it would come
Yeah.
from the home care agency. And I think they do some. They do.
They
You know,
do
they do
lots.
some, but
Yeah,
it's a balance. Once again, is that person a good educator? And you know, is the person, the caregiver, asking for it, or does the person,
yes.
even the caregiver, willing to ask? Because maybe they would think, oh no, you know, then I'm not going to be respected for my own knowledge. I mean, I think there's a lot of nuance there. So Sandra, with that home care agency, they could, I mean, provide the education and
Yeah.
probably do.
Well, we certainly did have very much one-on-one education. We had an educator that was specific to home care. We had the feedback from the client and their family and the home support workers as to what might be needed, because definitely the acuity of care required. You know, many people have lifts in their home and so on. So there was a very regular teams, actually teams of the workers who would be attending to that particular client would meet with the client, with the family in the home, and from there they would have the education that they needed to carry on. So that was an ongoing practice. That was back in the late 90s and 2000s, up until the time that I retired. So I don't know if that is the practice all across the province or what, but it definitely was a practice that was very much a part of the service of our home care agency at the time. So education, yes, it has to be ongoing. It has to be current. It has to be, again, client specific.
If I could make any observation, it's that we could probably spend the rest of the afternoon into the evening and the rest of the week talking about this. This has been a very, very rich panel discussion, very thoughtful questions from our audience. I'd like to thank all of you, those who've been online and our panelists as well, for being brave to do this. It can be nerve-wracking and you did a great job. We're running close to the end of our time, and I would like to thank everyone who's participated in the discussion. But before we sign off, I want to welcome Ron Swan, who's the chair of C.A.R.P Nova Scotia, who's going to provide some brief closing remarks and the call to action. I also want to remind everyone that the video recording of today's panel discussion is going to be shared on the McKechnie Institute's YouTube channel and website. So if you want to watch it over and over again, you're welcome to, and you can let others know that it's available to see. Thank you so much for the opportunity to be with you, and let's keep the conversation going. Ron, over to you.
Thank you, Mary Jane and panelists, for an excellent discussion. C.A.R.P Nova Scotia is proud to partner with the McKechnie Institute for Public Policy and Governance. Thanks goes to Kevin Quigley for his leadership and the McKechnie team for making today possible. This position paper on home care was created by C.A.R.P Nova Scotia's Health Advocacy Committee. Beverly Lawson is the chair of that committee. Ann Gillies was the lead author of the position paper document. Sandra Ball, Donelda Mcisac, Valerie White, Roseanne Burke, Carol Todd, and Rilla McDougall. Thank you for your dedication, many meetings, and endless hours of research. C.A.R.P Nova Scotia is one of 9 members of the Seniors Advisory Council of Nova Scotia. All our organizations, if you could share the screen on that possibly. We have 9 organizations that we meet with government on a monthly basis. And under the leadership of Terry Donovan and Vice Chair Bill Berryman, Council meets with the Department of Seniors. We advise government on issues that are important to older Nova Scotians. C.A.R.P Nova Scotia shared the position paper that we've been talking about today in April. And on May 23rd, Council adopted C.A.R.P's 5 priorities and rationale as its own. Collectively, this is giving us the voice of over 120,000 older Nova Scotians. So today I'm asking other organizations with a vested interest in Nova Scotia home care to join us so we can work together to bring home care home. Thank you.